I think where else? There you
All right,
go.
there we
Got
go. Wow, I just kind of pressed everything. It's
it.
okay. I can edit this out later on, but okay, so 5, 4, 3, 2, 1. Motherhood. Well, our topic is African American female health. And under the umbrella of this conversation, we are going to be discussing motherhood and midwifery. Tonight, I have with me Nubia Martin, and she's going to be telling me a lot about her experience as a midwife in America. Now, unfortunately, at this moment, I am a little bit far removed because I live in Germany. But what I have been hearing from you guys on the channel is that this is something we need to talk about. Um, Motherhood and mortality in the African American community in America. So I was lucky enough to find someone who is very knowledgeable, and she's going to tell us all about what her experiences are as it pertains to the topic. So if you guys aren't already liked and subscribed to the channel, please do so. And let's just get into it. So, Nubia, I'm going to put my face off.
Fine.
You have the floor.
Oh, thank you. Thank you so much, one, for having me and for amplifying this topic. It's so important, not just here in the States, but globally.
Mhm.
And I'll just give a little brief, introduction to who I am. My name is Nubia Earth Martin. I am a mother of five. I am the founder of a nonprofit organization called Birth from the Earth. And my background in terms of maternal health and women's health and wellness, I have an undergrad degree in sociology. I have a master's degree in midwifery. I have a postgraduate degree in international midwifery and maternal health. And I pursued an additional midwifery education that focuses on out of hospital birth. And I think that's going to come really in handy in this conversation when we talk about solutions to the current maternal mortality and morbidity rate crisis that we are experiencing in the US. So, yeah, that's me in a nutshell. And I guess, just to start out, I'll give a little bit of context to what we're dealing with in the US, but particularly in New York. So I am in Yonkers, New York, which is right outside of the Bronx.
Okay.
And in the US in general, Black women are dying 3 to 4 times more than their white counterparts in relation to pregnancy, childbirth, and the immediate postpartum period within 1 year of giving birth. But
All
in
right.
New York State, Black women are dying 8 to 12 times more than their white counterparts. So the question that people should be asking is why the disparities, but really more importantly, or just as important, why do we have such a huge difference in negative outcomes here in New York? So that's kind of what I want to dig into.
Okay.
But then also talk a lot about the solutions that we have come up with as a community, as grassroots birth workers, as families that are concerned, and people who are birthing. So yeah, I'm super excited to dig into this because it doesn't have to just be doom and gloom based on numbers. We also have qualitative data in addition to the quantitative data that is speaking to a resurgence of traditional midwifery and holistic practices of care.
Okay, so you mentioned something that I have heard before that is astounding to me. I find that this is one of the most scariest things to hear is that so many women are dying in this very sacred and special time in their lives when they become pregnant. Do you think that it is discouraging women at all to want to get pregnant or to have children? And what can you say about a lot of what I'm hearing in the narrative of weight and obesity?
Yeah,
So
yeah.
let's
Yeah. So, yeah, the first part of your question is, do I think that it's, having an impact on people deciding whether they're going to give birth or not? Absolutely. I hear a lot of people say, well, if I might not survive, I don't want to take that risk. If I'm at a higher risk of dying, then why would I even, attempt to go that route? And what I say to people in terms of how this narrative has taken shape is that we have to understand that there's nothing inherently wrong with us as people of color that puts us at a higher risk. It is more the way in which Black and Brown is treated in this country and has been since its inception that, really increases the risk of maternal mortality and morbidity. When we're talking about these deaths, we're talking one about preventable deaths, but we're also talking about systemic racism and the impact that that has on the type of care, the quality of care that somebody receives. And a lot of times there is negligence, there's this dismissal attitude that Black women don't feel pain in the same way, that they are either exaggerating their symptoms. And especially when we think about care in a clinical setting, you might spend an hour or two in the waiting area for your provider and then only be seen for about maybe 5 or 10 minutes. So this is where, midwifery really comes in, because midwifery is one-to-one individualized care. And when we're talking about, weight and obesity as a factor, that's actually not one of the number one reasons that, Black women die. The number one reasons are hemorrhage, sepsis, infection, pulmonary embolism, deep vein thrombosis, and cardiac issues. And the majority of those things that I just listed are complications that come from surgical births, so C-sections. And that is one of the things that we have a very high rate of here in the US, our cesarean rate. And when you have a cesarean, that is a major surgery, and there's going to be greater risks associated with that. But the rates of C-sections here in the States are way higher than what the national average should be and what is recommended by the World Health Organization, and what we see in other countries as well. And that is because the majority of people here in the States give birth in the hospital. And that's been like within the last, maybe a little less than 100 years that we've seen that big shift.
Okay, so let me get a little bit of a clearer picture about this. Is it that women are opting for like being convinced? Is it like last minute, like, hey, you have to have a cesarean because we need to meet our quota, or I got 5 more babies coming, we need to move this along? What is it that are people choosing to have cesarean? Because I have heard this as a thing
Mm-hmm.
in some countries, that you can
Yeah,
actually decide whether or not you can have just a cesarean as opposed to giving birth naturally. And is it an attitude on the part of the patient or the doctor or both that we feel like this is something that's not a big deal? Like you,
right,
it's major surgery. So
right.
can you talk a little bit
Mhm.
more about that?
Sure. So I will definitely say it's multifactorial. There are some countries where elective C-sections are on the rise, and it's because the way in which the cesarean is presented of, oh, it's quick and easy, you can schedule it, you know, all of these things. Why would you want to go through the pain of childbirth? You can be, completely numb. So that's one of the, things that kind of lure people in. But here in the States, I would say it's not it's not a result of people wanting to elect for a C-section. It's that we have a medical model of care approach to pregnancy that says, oh, your due date was yesterday, we should induce you. Oh, your BMI is high, we should induce you. Oh, you might be at risk for name anything, then we should induce you. And when you induce labor, when somebody's body doesn't naturally go into labor, many times the induction is either quote a failed induction, meaning what you want to happen, the person goes into labor, doesn't occur, or if you're using certain medications and synthetic forms of oxytocin, then you cause issues with the baby's heart rate, and now you've created an emergency situation where now we have to do an emergency C-section. But if you had not attempted to induce this person's labor or introduce foreign substances into their bodies, you wouldn't have a reason to do a C-section. So it's cause and effect for sure. And then there's also this misnomer that if you've had one C-section, that all of your future births need to be a C-section, which is absolutely not true.
Right. I've heard that. I've heard.
Yeah. Yeah. Is there a risk for uterine rupture? Yes. Is that risk less than 1%? Yes. Now, when they
Mm.
talk about that, do they state those numbers? No, but they scare people into believing that if you attempt a vaginal birth after a C-section, your uterus is going to rupture. You might end up having to have a hysterectomy. You might die, but they don't give you the perspective of it's less than 1% risk. And they also don't give you the perspective that it is actually safer to attempt a VBAC rather than go through a repeated abdominal surgery, because now you have to cut through more layers of scar tissue. There's a bigger risk for hemorrhage. There's a bigger risk for deep vein thrombosis. All of those risks now increase. And then after you've had maybe 2 or 3 cesareans, they want to tell you that it would be unsafe for you to get pregnant again. So you should probably tie your tube. So in my opinion, what's happening is a way in which to control who procreates and what their experience is, and to paint a narrative around why people are dying that induces fear and ultimately makes Black and Brown people question whether they should even procreate.
Mm, wow, it's that's so deep
Yeah,
on so many levels because then you hit the nail on the head when it comes to the attitude towards pregnancy and the medical approach towards it. Because what has happened ironically here is that people have taken the more natural approach. That's now in style, and this whole medical approach is now coming out. But there's a lot of pushback um, that's being put on midwifery because as a result, because people feel, well, let me not say people, let me say the medical community and doctors, shout out to all my doctors, feel threatened that this is going to be a major part of their practice that they will no longer have access to because women are just fed up in general, really, with how they are treated when they come into a doctor's office for pregnancy.
right,
So,
right. I totally agree with that. And I see, the same kind of attitude mirrored here. And I also want to say shout out to, the doctors, because I don't want to dismiss that in some circumstances, if somebody is having high risk pregnancy or there are risk factors there for them, that the most appropriate level of care may very well be an OBGYN, right? Or an MFM, or somebody who specializes in a higher level of care. But the majority of pregnancies are considered to be healthy and low risk. And the people who are the quote unquote experts on low risk pregnancy are midwives, right? So here in the States, we have this approach that everybody should be treated as high risk, right? Every pregnancy gets approached that way. They recommend that you birth in the hospital. 98% of births happen in hospitals, as opposed to other countries where it's like, okay, you are getting midwifery care unless you happen to risk out. And most people won't risk out because midwives have a model of care that includes preventive measures, right? So we talk about the things that could complicate a pregnancy, like high blood pressure, like diabetes, like anemia. And then we talk early in the pregnancy, or even if we're lucky enough, preconception, right? We talk about how to mitigate those things. We talk about dietary changes. We talk about lifestyle changes. We give a full kind of, synopsis of all the things that could be stressors in their life, and then talk about ways to reduce that stress. Because what we know is when the body is being thrown all of these stress hormones like cortisol and adrenaline, it impacts the placenta and the oxygen and the blood flow that a baby is getting. So when we hear these stats that Black women have a higher risk of preterm labor and stillbirth and low birth weight babies, I'm like, okay, well, wait, let's pause for a minute. Again, let's look historically at Black and brown women and how they've been treated and the stresses that they're dealing with just waking up every day, showing up as a Black woman in this world, right? And I'll say specifically in this country. So stress absolutely can affect all of those things, whether you go into labor early, whether you have a preterm baby, whether you have a low birth weight baby. So our role as community birth workers and midwives is to have a conversation with somebody that's not inducing fear about those things, but is asking them, what are the stressors in their life? Maybe they're the head of household. Maybe their job security is a little unstable. Uh, Maybe their childcare situation is, iffy, and all of these things kind of fall on their shoulders. So we want to make sure that they're having moments to talk about those things. They're having moments to meditate, to do yoga, to have a safe container or even calabash, I'll say, to actually share those things with the other people in their community, so they're not just holding it. Because the number one issue that they will tout as why Black women are dying from a medical basis is cardiomyopathies. However, when you look at the pie of all the different reasons that people are dying, cardiomyopathies, yes, makes up about 33%, but the whole rest of that pie are all the things that I mentioned earlier: the hemorrhage, the infection, the sepsis, all things related to C-section. So those make up a bigger portion, but when you cut those pieces into smaller segments, it looks as if cardiomyopathies is the biggest issue. But then my question to that and my follow-up like conversation is, well, why would women in their 20s and 30s be having congestive heart failure and cardiomyopathies, right? That's not normal. They haven't done enough bad living, to affect that. But if we think about their heart chakras and the deep-seated trauma that we have gone through that we have not had a chance to acknowledge and heal from, that does generation to generation impact our heart health, right? So these are the conversations that need to be had instead of, oh, you might be at risk for preeclampsia, so you should start taking baby aspirin as soon as you get pregnant. And it's like, well, wait a minute. We don't even know enough about what baby aspirin may or may not do long-term for a mother or a baby, but we're also not getting to the root of the issue. So, I definitely respect doctors, but their approach is more, it's medicalized. And a midwife's approach is more to kind of get to the root of what an issue might be and then figure out ways to actually find a cure and prevent it from occurring.
Okay, so talk a little bit about how your organization and how you're addressing some of these overall issues like trauma, because it seems a lot like it's therapy,
Yeah,
a lot of therapy, and it's much needed because of the way things are in America, and the way how women have been dealing with this kind of trauma their whole lives. And
yeah.
so, can you talk a little bit more about that?
Sure. Yeah. And I'll definitely say it's therapy, but it's creative therapy. It's not just
Yeah.
like sitting down, with a therapist. That could very well be part of somebody's healing, but it's also sitting in community with other mothers. It's sharing our experiences. It's using somatic techniques that are going to help rewire the way our body responds to a trauma that we've experienced before, so we don't relive that. It's dancing together. It's coming together and breaking bread, together as well. It is things like communal yoga, prenatal yoga, all of these, types of things. Um, and then having a space for that. So one of the things that Birth from the Earth, my nonprofit, did was we were able to open up a brick and mortar location right in the heart of downtown Yonkers, which is where I live. And that space has provided like a hub for healing. And it's not just, myself providing this, it's other people in the community, other mothers, other midwives, other birth workers who, are coming with their lived experience, coming with their professional experience, and then creating a space for us to collectively heal together. Education is a big cornerstone of the things that we do. So when somebody, reaches out and is like, I'm pregnant, I'm not sure where to start, we don't immediately.
So, okay, so we left off with some of the work that you're doing, and some of the community outreach that you're doing as it pertains to some of the services that women need when they are giving birth, or preparing for having a baby and
Right.
care after.
Yeah.
Let's pick up there.
Sure. We were talking about, the healing aspects of
Mhm.
like coming together as a community and making sure that there is a space and a container to kind of provide, those different types of things. And that could be, we'll do group prenatals, which I think is really beneficial because the one-to-one like setting with a clinical provider is not always conducive to the way that we want to do things. I invite if they want their, partner to come or their mother or their grandmother or their sister, or they want their children to be part of the prenatal visits, we encourage that, but then also really demystifying what's happening at a prenatal visit, right? So instead of,
Mm.
oh, your blood pressure is good. Oh yeah, your urine strip is good. No, they know exactly what every color on that urine strip means. They know how to make adjustments, to their, diet or their lifestyle based on what that urine strip is saying. They know what their normal blood pressure is so that if things are starting to creep up, it's not a surprise to them. They know how to palpate their bellies. Their partners know how to palpate their bellies. They know what position their babies are in. So these are the types of things that we do in community settings so that the birthing family is an integral part of their own care, right?
Right.
Takes out this, oh, the doctor kind of knows best. No, everybody is unique. And there's many circumstances where someone will say, I knew something was off, but the doctor kept saying, well, all the labs looked fine. Or they knew that everything was okay and they trusted their body to go into labor, but they were still being kind of pressured into being induced or having a C-section or whatever the case may be. So, when we provide the space for healing, that could be African dance, that could be prenatal yoga, that could be somatic healing techniques that actually help the body to rewire the way it responds to trauma. Because many people are coming from a place of, I had a really traumatic birth before. I don't want to go through that again, which I appreciate, but it's like, well, we have to kind of work our way through what happened so that history doesn't repeat itself.
Mhm.
So at the space that we opened up in the heart of downtown Yonkers called Earth Rounds, all of those things are happening, and different providers, families, midwives, birth workers are all bringing their different, talents and skill set to the healing. So it's a place that not just myself is providing services, but anybody in the community that has somebody to offer or has something rather to offer can do that, in that space.
Okay, and this is all, I know that in America, people have different kinds of healthcare, and so I'm always thinking about the cost.
Yeah,
And cost of having a child can be a stressor in itself,
yeah.
but then you have the additional cost of having a C-section or going through labor or having your doctor visits. How is this being paid for? And how is it that insurance and healthcare is a real stressor for pregnant women, people in the African American community?
Yeah. Yeah, for sure. So, what we aim to do is if somebody is pregnant and they're not sure exactly, where they want to birth or with whom,
Mhm.
my approach is not, oh, you should have a home birth, because that's not for everybody, but it's to give them the facts about each different setting, hospital, home birth, birthing center, and then what that kind of looks like to navigate that. So they can come to their own conclusion of what's the best place for me. And that can be based on their health and wellness. That could be based on their desire for where they want to birth. And oftentimes, the insurance does have, it plays a part in somebody making that decision because insurance will cover a hospital birth, no question, but they don't cover home birth or out of hospital birth in the same way. So, some of the ways that we kind of level the playing field there is my organization has an access to home birth fund. So, if somebody wants to have a home birth, say their insurance is not going to fully cover it, or maybe they're uninsured or underinsured, they can apply to the Access to Home Birth Fund, regardless of who their midwife is, right? Like they don't have to be working with me and my team. They could be working with any midwife that they resonate with. We will pay to their midwife funds on their behalf so that they can obtain access to a home birth. All of the different things that I just mentioned, the African dance, the village baby showers, the community prenatal, those are all free services that we offer. And that's just basically because I write grants, to kind of say these are the things that the community deserves. And I want it to be accessible to everybody. And often cost is a barrier, right? So we want to kind of make sure that that's not the reason that somebody doesn't get factual information, equitable care, and gets to choose the provider and the setting that is most conducive to their desires and their needs. So that's one of the ways that we get around that. But then I also kind of remind people the same way that, if you needed a new car, you kind of, budget for that too, that sometimes when you want to get the type of care that you need, you are going to have to invest in that a little bit. And when people are like, oh, well, I mean, if I go to the hospital, I can, tell them that I want this and tell them that I want that. And I'm like, well, yeah, you can, but it's kind of like pulling up to a McDonald's drive-through and asking for delicacy vegan food. They're going to be like, We have processed meat and fries. We don't have that here. So that's pretty much what happens in a hospital when someone's like, I want hands off, I want a physiologic birth, I don't want the routine IV. And they're like, well, what are you here for? Because that's what they do within the medical industrial complex. So it's not impossible to navigate a physiologic birth experience in a hospital setting, but it is challenging. And when you're in a moment of something so sacred as bringing forth life, you don't want to have to really negotiate, for that. So we want to make sure that people have options all around. They have factual information so that they can make those decisions. And then most importantly, that they have providers that look like them, are culturally respectful, and there's some familiarity in the care. So that's the other angle of it. And we train birth workers, and we help with holistic midwifery skills for those who are already in the process of becoming midwives.
Okay.
But the education is really geared towards working in a hospital setting, but we supplement that with what you would need to be prepared to serve within the community setting as well.
Okay, so that you brought up a really important point about midwifery and training to become a midwife
Yeah.
and what that looks like within the hospital setting. Are all hospitals open to having a midwife present when a woman is giving birth, if that's what she wants, or what is the dynamic with that?
Yeah, not unless that midwife is working at a hospital. So here in New York, for example, there are two pathways to licensed midwifery, right? You are either going to be a CNM, a certified nurse midwife, or a CM, a certified midwife. A certified nurse midwife has an undergrad degree in nursing and then a master's degree in midwifery. A CM has an undergrad degree in any discipline and then obtains a master's degree in midwifery. The one credential that's not recognized here in New York, and this is where those disparities of Black women die 8 to 12 times more in this state come into play, is a certified professional midwife. That midwife is trained specifically for out-of-hospital birth. So when you have a state that the only legal pathway is preparing you to serve in a hospital, it makes sense that we don't have a lot of home birth midwives. We don't have a lot of people skilled in out-of-hospital birth, and we have higher rates of maternal mortality, morbidity, because all of the evidence-based research, all of the statistics show that these are preventable deaths that are happening in the hospital. And even evidence-based research says that if you're having a healthy, low-risk pregnancy, the safest place for you to give birth is not in a hospital. So it kind of makes no sense that New York as a state is blocking the pathway to providers who are trained in out-of-hospital birth, because that's what they need that option to reduce the amount of preventable deaths that are happening. So we're working on a bill here in New York to get that passed. Yeah.
Okay, to get that bill passed so that you have the options.
Certified professional midwife, right? So people will still have, the option of birthing in a hospital with an OBGYN. That won't take away from that choice. They'll still have the option of birthing in a hospital that has midwives. They'll still have the option of birthing in home with either a CM or a CNM or a CPM, but the CPM is the one who is specifically trained in out-of-hospital community birth.
Okay.
Yeah.
That sounds amazing. That sounds great.
Yeah.
I know that we have to wrap it up. We've had we've had a few technical difficulties, guys. I'm sorry
Right.
about that, but I just want to conclude. We're not going to be able to cover everything. I'm so sorry.
Yeah.
There's so much that I wanted to ask and probe at, but I'm going to end with one last question.
Sure.
When it comes to the attitude towards having children, in our community, what are some of the things, like you talk about investment and you talk about healing from trauma? If you could just say 3 things that are the most important thing for any woman who's thinking about having a child and having a midwife or home birth, what would those 3 things be?
Yeah, I think first and foremost is that the power is completely within you. And that's one of the things that I think midwives do a wonderful job of, is letting this person know that we don't deliver your baby, you're going to deliver your baby. We might catch and receive your baby, but the power is completely within you. 2 would be that you have the right to have the birth that you desire, the way that you want, with the people that you want surrounding you. And 3 would probably be just to reiterate that there is nothing inherently wrong with us in terms of contributing to higher rates of death. It's the way in which we are treated. So we also have the right to seek care from somebody who is going to give us compassion and just hold space for us to actually bring to fruition the birth experience that we want and desire.
Great. Awesome. Nabia, thank you so much for being with us tonight. I
Thank
really,
you.
really appreciate your contribution to the channel. Guys, if you are interested in finding out more information, I can link some contact information, how you can donate to this cause. And I'll see you guys in the next one. And of course, please always remember to stay safe and stay free.